Hi, everybody. My name is Stephen Bengis. I'm the Executive Director of NEARI and NEARI Press, and I want to welcome you today to today's webinar, A Contemporary Overview of Juvenile Sexual Risk Assessments by Phil Rich. Before I turn this over to Phil, I want to take a moment to tell you about NEARI Press. For those of you who may be new to us, our mission is to share the cutting-edge research and best practices emerging in our field. Now, for many years, we accomplished that mission only through book sales. But with changes in both the publishing and the technology worlds, we're exploring what it means to maintain our mission while moving towards a more expansive view of our work as a knowledge dissemination organization. Now, with that new goal, over the last 5 years, we've offered online courses, free newsletters, face-to-face workshops, and now most recently, these webinars by some of our internationally recognized authors. But unlike many other publishers, each of us here at NEARI Press is a professional working alongside you in the field. And when we seek to determine what are the most pressing questions, the most urgent training needs, or the most desired presenters, we can accomplish that goal much better if we have your suggestions, input, and feedback. And whether positive or negative, we really appreciate the engagement with you. So please contact us with your questions, critiques, or suggestions. And just out of curiosity, how many people have participated in a NEARI Press webinar before? And Greg, would you mind taking this poll for me? So it looks to me, Greg, that about 2/3 of the people have taken a webinar before, and about 1/3 of you are newcomers. So welcome to those of you who are coming back. And we're sure delighted to have so many new people on with us as well. I'm going to talk more about this at the end, but if you find these webinars helpful, we hope that you'll consider becoming a sponsor of the series, because like National Public Radio, it really is your donations that help make this series happen. Similar to NPR, we're going to offer you a free gift of 2 of our books for becoming a sponsor, Current Perspectives and Current Applications. And we're also happy to inform you that we're now able to offer CE credits for these webinars. So truly, it's a win-win for all of us, and it really is your support that allows us to continue to bring you these free resources as well. Just a couple of housekeeping things to do before I go on to let Phil begin. One, tell you again that the upcoming PowerPoint has been posted on the NEARI Press website, and next week we will be posting a recording of the webinar for those of you who want to listen to it again. When the workshop's over, please be sure to close out your account, and we'll be sending you an evaluation. And again, we really would appreciate your feedback. And last, as previously stated, we now offer CE credits both for psychologists and social workers for the webinars. And to get your CEs, follow the instructions on the webinar page and take the post-assessment test, and then you'll have to purchase your CEs at a very nominal fee. As with all workshops, I want to let you know the learning objectives for the webinar. That's to understand the state of empirical research into juvenile sexual risk assessment instruments, to understand the strengths and weaknesses of juvenile sexual risk assessment, and last, to understand the value of juvenile sexual risk assessment in establishing the basis for treatment and targets for treatment. In terms of, I want to just take a moment to introduce Phil to you. And he needs no introduction for many of you who are listening. Phil presents, trains, and consults nationally and internationally, and is currently in private practice as a consultant and trainer specializing in work with sexually abusive youth. Phil has worked extensively with sexually troubled youth and the staff working with this client group. He's written 4 books and numerous articles and chapters addressing the assessment and treatment of sexually abusive youth. What I'd like to mention is one book in particular, Juvenile Sexual Offenders, A Comprehensive Guide to Risk Evaluation. And that book provides crucial current literature about sexual offenders and offers a timely overview of the process of risk evaluation of juvenile sexual offenders. It contains practical information in effectively conducting thorough evaluations of juvenile sexual offenders and topics including projecting risk and using the instruments. Professionals in the field, including clinicians and clinicians who do not exclusively work with juvenile sex offenders, but who still need to evaluate and assess risk with sexually reactive children in their practices. For supervisors and administrators, they'll all receive a detailed guidelines on how to gauge potential risk of reoffense. I also, and I apologize for you having to look at one particular slide, but I don't want to be messing around with the technology and make you wait. So before I turn this over to Phil, I want to let you know that today's webinar serves as an introduction for Phil's 3-day certification course, which will take place in June in Massachusetts. This 3-day course will provide instruction and practice experience in administration of sexual risk assessment for juveniles who have previously engaged in sexually abusive behavior. The course will cover the process of risk assessment from theory, method, and instrumentation to case study and applied practice, including case formulation. Participants will gain a thorough understanding of juvenile sexual risk assessment, understand the use of risk assessment instruments, and gain feedback-driven practice experience. We hope that any number of you who are listening to the webinar will come and join us for a very exciting 3-day intensive with Phil. If you need more information or to register, please contact Diane Langelier at 413-540-0712 extension 14. And all of that information is also available on the NEARI Press website. So without further comment, here's Phil Rich. Phil, it's a pleasure to have you present today.
Thanks, Steve. Can people hear me? Steve, can you hear me?
I can.
Am I being heard out there?
Yes.
Hello? Okay. Okay, you can hear me and you can see my screen, so we're good to go? Okay. All right, so I'm Phil. And, you know, I for those of you ever heard me talk before, you know I always have a lot of material. So I have a lot of material. I'm going to get through it in about 30 minutes, so we have time to talk after. But this material is all available to you through the handout that will be available. And you can see my email contact right there on that front screen. And the very last screen, I'll put it there again. So you can also feel free to contact me directly. So, excuse me. Excuse me 1 second. So I'm going to move it through quickly. A lot of material. You know, one of the advantages or disadvantages of webinars where you're not interacting all the time is you can actually cover a lot of material. So I am going to cover a lot and hopefully give you a pretty broad overview, which will, I hope, meet the goals that we set, the goals and objectives that Steve read. So we start, of course, with a definition of risk assessment, and we are talking, I suppose, a combination of this is what we've long thought about risk, but we're also going to be talking about what are we thinking about risk today? What does it mean in terms of risk assessment? But certainly we start with the idea that we're really talking about somebody's capacity or potential or the likelihood, pick the right word, the possibility that somebody will re-engage. And that's a key right there. We're not really talking about first-time behaviors. We're talking about, in effect, re-engagement or a re-abuse or a re-offense. So we're talking about something that's building on some prior history. And risk assessment wants us to think about what's the likelihood that someone's going to re-engage under certain circumstances, which includes environmental conditions. So that's going to be a key piece here. We're also thinking about not simply the individual, but the individual in his or her environment. And so when we think about risk assessment, we're thinking about risk factors, the things that we think are related to harmful behavior, in this case, sexually troubled behavior, the circumstances that drive behavior, that bring those behaviors into reality, and conditions that allow harmful behaviors to emerge. So already we can see very briefly, we've got a combination of things at play there. We are really assessing risk, not necessarily at the moment that you're sitting down with that individual, but really where there's inadequate supervision or no supervision at all, and also, importantly, where there's access to victims. So it helps us to recognize that assessment is really about somebody's behavior in effect in the community or in a relatively open access environment where there are potential victims. We can also think of risk, though, not simply as rejection of what somebody might do in the future under certain circumstances, but what might happen if that individual, in this case, we're talking about children and adolescents, if that youth is not provided with the sort of care that he or she probably a he when it comes to sexually abusive behavior. I think you probably all are aware that by far and away, as with violent crime in general, but with sexually abusive behavior, it's 96, 95, somewhere in that range, 95, 96% male. So we're talking about what might happen if the juvenile is not provided with care or supervision or treatment or monitoring. But even when we assess high risk, it doesn't necessarily mean that that kid is going to reoffend. It's not a certainty. And in fact, every model, and we'll take a look at that again very briefly as we move through the next 25 minutes or so. But given that any of the models of risk assessment we have a week, we may want to think about the assessment of risk as a way of recognizing the preponderance of risk factors. What sort of risk factors are present in this individual's life? Factors that are present in that individual's life. And I'll highlight that again, because here we're talking about risk for that particular youth, not the youth next door, not the youth who's perhaps in the same treatment program in the room over, if it's a residential setting. We're talking about the risk factors that are present in that particular youth's life. And so when we think about risk assessment, we can think of it as a way of, in effect, measuring the presence, the quantity, the effect, and the influence of risk factors in that individual's life. So when we think of it from that way, when we think about an assigned risk level, whether it's low or it's moderate or it's high, I see my question light flashing here, so let me see if this means something. Okay, I don't see anything aimed at me. I wondered for a moment if that meant there was a problem. So when we think about risk level, moderate, low, high, whatever system we might use, it really in some ways represents the number and the type of risk factors that are pertinent to each youth individually, and really important, the areas of risk that are going to continue to need treatment and supervision, both as an ongoing aspect of treatment, but also potentially following discharge. So already we can sort of get the idea that risk assessment goes beyond just simply assessing risk. It tells us something about that individual and what perhaps he or she needs. From that same perspective, when we think about treatment, we think about rehabilitation, especially we're talking about adolescents. We also see, from what I've just said, that risk factors really become pointers. They give us a sense of what we should be looking at in treatment. So rather than being a certain and definite prediction that this is going to happen, it really tells us much more about what's necessary in that youth's life now. And the fact is, from virtually every study that's been written on sexual recidivism among sexually abusive youth, most youth are not going to reoffend sexually following treatment. Of course, some will, most will not. Most robust studies suggest that maybe 10 to 15% of youth will reoffend. That's no small number. We don't want to just sort of sneeze at that, but most youth will not reoffend. And in fact, many studies come up with lower rates of sexual recidivism than that. We think about risk, we see two types of risk. We see internal risk, in which we can recognize that it's reasonable for us to think, well, some risk is carried around within that individual himself. They're held within him. They're there due to biology, perhaps, developmental experiences more likely. And the sort of risk factors that we're talking about might include attitudes and beliefs, relationships, interests that are sexual and non-sexual nature, regulation, etc. These are good examples of internal risk that belong to the individual regardless of how they got in there. But we also see risk in the environment that exists outside of the individual and really affects the individual in every way. I see that light, that little hand coming up again. Okay, well, I don't see any questions or comments aimed at me at the moment. Again, I'm wondering what it means there's a technical problem. But in this case, let me move on. External risk really involves the external environment in which that child lives and frankly grew up, but continues to live now independently, existing of the individual child. Social attitudes, family problems or dysfunction, exposure to domestic violence, which shows up in virtually every study of risk for kids of any kind, risk for what might happen to them or what they might do, economic hardship, etc. So we can see external risks as something that exists outside of the individual, but there's a relationship between internal and external risk. And in this case, when I talk about risk factors, it's anything that contributes to or points to the possibility of harm, or increases the probability of harm. Risk factors aren't necessarily causative. Together they may be, but they certainly increase probability. And as I've just said, on their own, they may not be causative, but when they come together and interact with other risk factors, it strengthens the power of any individual risk factor, and as a whole, influences risk and harmful behavior in a way that an individual factor may not. When we think about things that have happened, things that I've done, things that have happened to me, my age at the time, these things are static risk factors. They can't be affected. They can't be changed. They've occurred. There's nothing we can do about those. It's important information for us. If we don't get new information, those factors remain fixed. That becomes, in effect, the history that led to that youth being evaluated today. When we think about dynamic risk factors, we see these as things in action, family instability, anger, self-regulation. These are dynamic risk factors because they are active in the present day. These are not simply important risk factors for us to think about, but we need to recognize that these can change with time. And they, in many cases, will change with time, if only because we're talking about adolescence in development. One of the important characteristics is that when we reduce risk factors, that's associated with reduced recidivism rates. So working on dynamic risk factors is key. And of course, they then become the target of treatment because treatment is aiming at changing those factors. We can't change those static factors. Risk assessment helps us to see those dynamic risk factors in action. Two types of risk assessment: actuarial, which is a mechanical or arithmetic statistical analysis of statistically derived risk factors. It's a very important model of risk assessment, and it results in a statistical projection of future trends. For instance, there's a 65% chance that this individual is going to reoffend sexually within a 5-year period, for example. It doesn't pay much attention, if any attention, between those internal risk factors and those external risk factors. It really sees internal risk, including static history, as the key to predicting statistically future behavior. And so it doesn't take into account any kind of environmental factor at all. We think only about those factors that are directly related to the individual, usually of an entirely static nature, things that can't be changed: age, what he's done, relationships he may have had. We see these things as unchanging in a statistical assessment, and we can predict future behavior. We compare the individual to a class of individuals rather than looking at the individual as an individual. We also, as a result, can't really understand the individual. We can perhaps project what he or she may do in the future, but there's no meaning to that. It doesn't help us to understand the individual or what we might do about it. When we switch to a model of clinical risk assessment, which is the almost certainly the only choice you're going to have when you do juvenile risk assessments. There's only one juvenile statistical tool, and that's only for use in 4 states at the moment because it's a statistical tool. So most of you are going to be facing clinical risk. If you happen to be in California, or you're in Georgia or Iowa or Utah, you can use the JSORAT, which is the one actuarial instrument, even though it's still in development. Clinical risk assessment, though, instead of looking at things from a statistical perspective, we really are observing the factors. We're trying to understand that individual in the context of his life and pick out those risk factors based on our professional interactions and knowledge. It's a much more dynamic model, and we understand in this model that risk exists within individuals, within their environment, and in the interactions, of course, between the individual and the external environment. And that includes, not as is the case with actuarial assessments, not simply looking at static factors, but looking at static factors, which is certainly really important, and also dynamic factors, those things that can change and become the targets of treatment. From a model like that, we can gather a lot of information, the maximum amount of information that we can use to really draw conclusions about that individual. We're going to learn a lot about that individual by engaging in a clinical assessment where we have to be asking questions, we have to be reading materials, we have to go beyond simply looking at the static history. And that's particularly important, of course, when we talk about kids that we recognize as going through important developmental changes and experiences, not only at the time that the offense happened, but now while you're going through the evaluation, and tomorrow, and next week, and next month. So particularly important that we think about clinically assessing dynamic risk. Nevertheless, when we look at risk factors of either kind, in the sense of actuarial or clinical, neither model says, look, any single risk factor's got enough power. No matter how powerful a single risk factor may be, it's not powerful enough to cause criminal behavior. It's certainly not powerful enough to drive sexually troubled behavior or abusive behavior. In both cases, it's that interplay, that accumulation, that the fact that one risk factor affects and influences, and perhaps itself is amplified by the presence of other risk factors, again, in the individual or in the individual's environment. And so we see that combination of risk factors, multiple risk factors, that ultimately allow antisocial behavior to emerge. And the fact is, of course, it's different for different people. Different people walk down different paths with different risk factors. We want to understand those risk factors for the individuals we work with. We see the static offense. I've already mentioned this. That's the history. And we have to have a static history. We're going to be doing forensic risk assessments. So it's always an assessment for recidivism rather than first-time behavior. If you have questions beyond which I'm saying now, and we don't get a chance to talk about it after, you can certainly feel free to email me at any time. And again, I'll put my email up again at the end of the session. We look at the past in part to highlight possible future behavior. At the same time, though, we don't want to just count beans, right? We want to be understanding what's going on, because when we understand what somebody's done and perhaps why they've done it and their experiences, it can help us to think about what that person might do in the future if things don't change, if we understand why it happened and under the circumstances that the prior behavior happened. When we do that, we can start to project a trend, right? We sometimes call that trajectory, a trend into the future, which, if uninterrupted, might help us to recognize, boy, if this is going to happen again. In some simplistic way, that's what risk assessment is. We're projecting statistically or clinically a pathway into the future. When we say high risk, however we get to that label, we're really projecting the idea that there's a trajectory that's going to lead to the same behaviors. Most juvenile assessment instruments, as I've said, are clinical, they're dynamic, they're built around empirically identified risk factors that we find in the literature. They not only help to predict risk, but increasingly we see them as tools for case management and tools by which we can plan treatment goals because of those dynamic risk factors. It's a dynamic process, and it recognizes that idea that we might simply use risk assessments as Bo and colleagues said back in '97. All the, by the way, references that I cite are at the very end of this PowerPoint, which you'll have in the handout. It avoids that possibility that, as Bo and colleagues said, that risk instruments, and they were really talking about actuarial instruments, are simply what they call passive predictions of limited practical use. They were involved in treatment, and particularly with kids, we're really not concerned with what they did. We're concerned with what they might do. We want to change. We want to lower risk. We want to change that trajectory. We look at lots of elements that are not likely to be taken into account when we look at, adult assessments. The fact that they're still in development, the context of their life and their relationships, and the context of child and adolescent development in general. Factors in their environment play a much more important role than factors in adult offenders' environments. Not because they're not important for adult offenders, but they have different weight. Peer groups, family dynamics, pro-social or antisocial activities, etc. These are the things that we want to be looking at in juvenile risk assessment, not simply going down a checklist. Caldwell and Dickinson or risk assessment with juveniles should be considered reliable, relatively reliable, only over a relatively short period of time. And that's because kids are changing, kids are growing. The 14-year-old in some respects is similar to, but in other respects very different than the 16-year-old in a 2-year period. Risk assessment for juveniles focuses on developmental and social change and context. So unlike most adult systems, not all, but most adult instruments, the most currently used, the JSOAP and the eraser, for instance, which many of you will be familiar with, define time limitations or expiration dates for the assessment of risk. Here's a fairly recent article by Phaneuf and Letourneau. Evaluators should focus on short-term risk in adolescents, the fluid nature of risk and sexuality among juveniles, the low base rate of sexual recidivism among juveniles, meaning, as I said before, relatively speaking, low recidivism rates, and positive responses that the literature notes in terms of kids who go into treatment. Shifting a little bit when we think about where risk assessment is arriving at, where it's going, not just risk factors, but protective factors as well, in which we understand, as Rudder pointed out, he was talking about general risk, not risk for sexually troubled behavior, but general risk for kids. Seems obvious that we should be looking at things that protect kids against antisocial behavior, as well as those things that predispose us to it. And that's not Rudder in particular, but that kind of model in some ways has marked the biggest shift in risk assessment, probably coming to the fore in the last 5 years or so, maybe even less than that. But the idea that we're not simply looking at risk, we also want to be looking at protection against risk. And together we might think of as risk as that risk and needs assessment, and even the assessment of strengths as well. That's what protective factors are. They are complicated. So here's Jester and his colleagues, again, talking about risk in general, but they point out that risk and protection are often sort of the opposite ends of the same variable. You know, if it's not raining, then it's sunny out. But of course, that means that risk and protection from that perspective are very correlated because they're on the same continuum. But they point out makes it very difficult to understand the role of protection. And they argue that that's not the case, that protective factors exist independently of risk factors, not just as the opposite. And in a simple way, we can best understand the presence of risk, of protective factors only in the presence of risk, not just the opposite of risk. It doesn't make sense to carry an umbrella around when it's beautiful sunshine. So it's difficult for us, and I would sort of caution us to think about this when we try to estimate the power of protective factors. Does one protective factor and one risk factor neutralize one another, for instance? And the answer is, of course not. Nevertheless, even though we don't really fully understand the mechanisms, I don't know how long it will take us to do that or if we ever will. But certainly, even given the difficulty, we've got to take into account the presence or the absence of protective factors. Actuarial models just look at static risk. Clinical model recognizes an interaction between risk elements and between protective elements and between risk and protection. But it makes it difficult, and I hope you can see just what I'm saying. As soon as you add a new set of variables, protective factors, it makes what's already a difficult process more difficult, but very important. So protective factors is what we're talking about. Again, we conceptualize them only when we think about risk factors. And these are anything that buffer against risk or decrease potential or guard against, or simply help neutralize some risk factors. And they can be found, like those risk factors, within the individual and within the individual's environment, existing independently of the individual. When we use a risk assessment instrument on its own, at best, it's a screening tool, right? We don't have we can't do an awful lot with it on its own. Here we shift, again, quickly. We've got about another 10 or 11 minutes or so. When we shift to the risk assessment instrument, thinking about it on its own, we can best think about it as a screening instrument. If we want to do a more comprehensive assessment that gives us ideas and information that we can base decisions upon, recommendations, as well as estimates of what might happen, we want to do comprehensive assessments. We want to understand the likelihood of a sexual reoffense based upon prior behavior, the static history, circumstances, context, not just in which the behavior happened, but how it developed. And ultimately, what risk factors, what protective factors are at play in the individual life of that person who we're assessing. When we think about assessing risk, that assessment gives us a broad formulation that we can base upon our ideas upon. We understand the circumstances. We understand, when I say the natural history, I mean the way that the sexually troubled behavior and the ideas that go with it, and sometimes the relationships, how it developed, what was its natural history, and what's the prognosis if things remain unchanged, as well as, well, these are the things that we want to apply perhaps that will bring about change, treatment and case management. It gives us maximum information, huge amounts of information, the more the better, frankly, upon which we can base risk, not simply use a risk assessment tool as a screening instrument, but understand what we're talking about with respect to that particular individual. And that gives us the capacity to make really well-informed decisions, well-informed recommendations about the treatment needs, the treatment interventions that are geared to that particular individual. We're not mind readers, of course. We do our best, but a rich environment of information provides us with the opportunity to engage in comprehensive risk assessment. When we look at the tools that we use, I mentioned a couple of them before, the eraser and the JSOAP, for instance, the assessment instrument that is intended to guide us to avoid the possibility that assessments will be carried in a poorly defined fashion, gives us structure, it gives us definition, it gives us consistency. It helps to improve reliability when two different assessors use the instrument. We get inter-rater reliability. Actuarial assessment is always guided by an instrument like that because it follows rules and it asks set specific questions. That's clearly a strength. When we use an assessment tool that's structured for clinical assessment, it equally provides organization, structure, definition, has weaknesses, but it offers a really guided approach or a structure or a anchored approach to professional judgment. Sometimes instruments like this are called instruments for structured professional judgment. When we think about these instruments, for instance, again, the eraser, the Mega is a new one that some of you will be familiar with, the JSO, the JRAT, the AIM2, which is really out of the UK, but some people do use it here, as examples. We should think about at least these 14 criteria when we think about picking an instrument and thinking about an instrument. Is it comprehensive? Not only in depth, as much as you can during an assessment, but also breadth, the amount of information collected. Is it logically organized? Does it make sense? Does it explain the design, the intent, and the limitations? Are there clear instructions for use? All of these things improve the use and improve inter-rater reliability. Does it include both static and dynamic factors that are supported by the professional literature? Is there a sufficient range of dynamic risk factors? And is there a clear definition of each risk factor so we know what it is we're actually assessing? Does it cover multiple areas of risk? Behavior, interactions, relationships, and does it do that in multiple life domains, in the environment, in school, for instance, and the home? Is there a rational and well-defined scoring system? Does it allow us to weight different risk factors? It's clear that some risk factors, in some cases, are probably more significant than others. Does it allow us to consolidate all of the data we've gathered? And does it yield results that are obvious to the reader, transparent results? Is it clearly designed and oriented toward the particular population that we're using it for? And does it allow us to reevaluate risk? Because risk is dynamic, particularly in the case of kids who are changing. So does it allow for reevaluation? Validation, again, I'm going to give you that quick look. In terms of validation, the literature, unfortunately, is scattered. Listen, I love risk assessment. So I have a vested interest in risk assessment, but the reality is that literature is really inconsistent. It doesn't really offer statistical support. When you hear that an instrument is validated, a clinical instrument, the chances are one research study may have found some validation, but overall, the clinical and research literature provides mixed results, inconsistent results, in some cases, contradictory results. And so I think that we're not able to say that our instruments really are empirically validated. We're in the process. But right now, our instruments in terms of a study show inconsistent levels of validation, particularly the predictive level, which is to say, does this actually tell us what an individual might do? And validation at that level is always studied as a research study of not a single case, but ideally dozens of cases, and the larger the sample, the better. In general, the instruments are far from validated, and that really, I think, significantly and importantly reduces our capacity to really rely on them to actually predict recidivism or to inform juvenile policy decisions or court decisions. From a 2009 study, current instruments, important developmental milestones, but not yet complete. At this time, research doesn't support the use of any of the instruments. No single instrument or combination of instruments has demonstrated adequate predictive power. That's important for us. Doesn't mean we shouldn't use these instruments, but we want to be cautious. Until new instruments are better validated, evaluations are a balancing act between the needs to provide the courts with information and the serious limitations of those instruments, because not only is public safety at risk, but so is the growth and development of that individual youth and his or her family. Fanoff and Letourneau recommend until new instruments are better validated or existing instruments are better validated, balancing act between the need to provide the courts and the serious limitations. That's actually a repeat of the last slide, my apologies. However, even though there are weaknesses, Jody Villion and colleagues, and Jody has been somebody engaged in very objective study, but they say, look, even though there are difficulties, risk assessment instruments offer clear benefits over unstructured judgments. And they say that even though the focus in research has been on recidivism, these instruments help us to manage risk, plan treatment to prevent reoffense. And they point out that if we pay attention to the utility of the tools for case management and treatment planning purposes, we get beyond simply predicting reoffense, and we move towards the prevention of sexual reoffense. Here's Robert Prentke, who's and Sue Right-Hand. They are the primary authors of the JSOAP 2010 study. They say, similarly, even though there are concerns around predictive validity, the JSOAP, they're talking about that particular instrument, may be useful for making case management decisions, especially useful for treatment planning. So we move to the last few slides. It's clear we're not just simply talking about defining a level of risk. We're talking more about developing an understanding of the individual youth who we are evaluating and whom we or somebody else is going to be working. We are concerned not just with estimating risk, but really preventing recidivism. This little picture at the bottom of the screen, watch it over the next couple of slides. Here's Steve Bengis, who introduced us today, David Prescott, Joan Tabachnick, who's also in our webinar today. And every month, NEARI puts out a great newsletter. This is from one of their newsletters. I highly recommend them. They're on the NEARI site, but for the sake of time, I'll move on. But this is from a 2012 letter. Assessment is complicated. Current measures, our risk assessment instruments help, but they're not standalone instruments. We've got to be careful about assessing reoffense for each individual. And we've got to take the time to develop specialized knowledge in this area. Given those low base rates, they say, and I agree heartily, the use of measures that guide safety, that help us to manage risk, plan treatment might be a better way to proceed than simply making statements about risk. So you can see that picture. Look what happens when you blow it up. The detail starts to get fuzzy. Suddenly, the thing that we thought was so clear is less clear, and we also start to see other things. So we go closer still, we get fuzzier, and yet we see new details emerging. And if you have a good enough monitor and you're close enough, you'll see that this picture is actually made up of hundreds of other photographs. So not only does the picture that perhaps we thought we saw become fuzzier, but the details that we never imagined were there before suddenly become clear to us. We want to remain well informed. There is a covenant between the people who develop these risk assessment instruments, but the users of those instruments. At the author end, the covenant is they're going to do the best they can to produce reliable, valid, well-developed instruments. But at our end, the evaluator's end, we're agreeing that we're going to get the kind of training that we need for managed practice, not simply going to use it as a risk tool. Professionals need to be extremely careful about assessing the reoffense risk and take the time to obtain specialized knowledge. Highlighting that is to say, the responsibility of the end user, the evaluator. Practitioners have obligations to always use measures appropriately, ensure they're trained in the administration, and most importantly, make sure the assessment process culminates in a developmental formulation, an etiological formulation that helps us to understand origins of the problem that's based around the individual's features alongside the features they share with other offenders. So that's the end of the presentation. There's my email address and there's my website address. So I'm very easy to get in touch with. And of course, you can get in touch with me through NEARI. So I am assuming this has gone well, and someone's now going to take over the presentation for questions.
Phil, thank you. That was a wonderful presentation and orientation to risk assessment. You commented several times about the need for deeper training and for folks who do this to really be well qualified to do the work. So I want to just, this is a slide I would have presented earlier. This is the presentation that you're going to be doing in June, 2nd, 3rd, and 4th of June on contemporary overview of juvenile sexual risk assessment. So for those of you who've been listening who realize the wealth of knowledge that Phil possesses in this area, you may want to jump on board because we're going to limit it to about 40 folks. Also, just to let you know that over the past 3 or 4 years, Phil and a group of us in Massachusetts have been working on looking at all of risk assessments and trying to come up with a new protocol for the work, and we call it the MCAS. It's the MASOC Child Adolescent Planning Protocol, and we're going to be rolling this out at the MASOC MATSA conference in April. So it's in a one-day event. The conference is 3 days, but the MCAP will be presented in the first full day. So for those of you who are looking for another place for training, that might be something you want to explore as well. So Phil, as you were talking, there were a number of questions that people ask. So let me, and I'm going to throw on my screen here so I can.
Have I appeared on the screen, by the way, Steve? I just switched on my camera.
You did appear. So
okay. I don't really look like this, though.
It's okay. You look fine.
Okay. I swear I don't really look like this. Yeah.
So, first question came to us from a colleague in the Netherlands who was asking what risk assessment tools should be used. And he was more working with adults, but to look at those with serious learning disabilities and mental health problems.
Well, if you're using, I have to really stay with adults on that. Although I think that, that's problematic in itself. The actuarial adult instruments, in theory can be used with intellectually disabled, developmentally disabled adults, but more research really every year comes up, including research done by the people who've created those assessment tools that I think probably makes the tools more limited. The only instrument that's really has been developed for adults, and again, we're talking about age 18 and up, for sexually abusive adults with intellectual disabilities is the armadillo, which is not spelt like the animal, but it's close enough. And if you email me, I'll send you the spelling and their website. But if you look it up, it's ARMIDILI, LO-S because of the sexual behavior. And that's not an actuarial tool. It's a clinical tool. The same folks who have developed that, and it gets a lot of use, the same folks who have developed that are in the process of trying to develop a youth version of it. But I think, when I say they're a long way away, it could be next year. It could even be this year, but I think they still have a lot of work to do on it. That's the only instrument for adults. The MEGA, which some of you may be familiar with, which is an adolescent instrument, there's not an awful lot known about it. It's been in research for quite a long time by the author, and in the last year or so, she's released it. Unlike the others, it costs money, and you can't use it unless you get a training in it. But the MEGA purports to be able to effectively provide assessments for boys and girls with intellectual disabilities. So the MEGA is something that purports to do that. I think that you can also use the instruments that are available, but use them in the context, meaning the eraser or the JSOAP, for instance, but use them in having information about people who are intellectually disabled. I'm the author of an instrument called the JRAT, Juvenile Risk Assessment Tool, and years ago we just put together a cognitively impaired version of that added some material. But really, you could certainly use any instrument as long as you use it in the context of the client. And that means that you have to obviously have knowledge about intellectually disabled populations in order to use them. So I hope that's a broad and a good enough answer.
So let me ask you this. This is something that comes up often when we start talking is, what about the girls? Are the risk factors for girls the same as for boys, including the same weighting? And it seems that the questioner says it seems like no risk assessment instrument is strong for girls. So what are your thoughts?
Well, two things. The MEGA, when I say claims, I don't mean that in quotation marks around it. It's sort of it's from their own research, and so there's no independent research, but it's still a new instrument. So the MEGA really purports to be an instrument that can assess males and females, any IQ, from age 5 through 19. So it says, look, we've got cutoff scores in here, and you can use this instrument. And again, if you're interested and you can't find information about it, just email me and I'll send you the link to the author, who's certainly interested in connecting with people. So that one says you can do girls. The eraser claims, I'll use that term again, but I don't mean it in a derogatory fashion, that you can use the eraser with males and females, young men, young women, boys, girls. and Jim Whirling, some of you will know, who is the primary author. I think Jim argues, reasonably, look, these are broad enough kind of categories. You have to individualize them, but antisocial behavior is antisocial behavior. I'm not sure that I agree, because boys' antisocial behavior, for instance, is not necessarily the same as girls' antisocial behavior. If we're looking for, for argument's sake, to use a simplistic model, smashing out windows as an example of antisocial behavior, we may not notice it in that girl that we're assessing because she doesn't do that. Maybe she spreads rumors about people instead. So the eraser says, though, you can use it for girls. The Megget is intended for girls. Beyond that, though, I think that you can use these instruments as a guide for populations that they weren't specifically aimed at. So I think you can use them for girls. The JSOP says this is for boys, for instance, but certainly it's a relevant way to look at girls, knowing that there really is still a paucity of information. There isn't a lot out there. Same with younger kids, pre-adolescents. But that stuff is building. 10 years ago, we didn't have a very good literature regarding adolescents with sexually abusive behavior. Now we have a much better literature. My guess is that's going to come with younger children and females, particularly if there's a need. So, and there are people out there who certainly work with females who can, I think, are quite often happy to talk to people if you want to, talk to them about their expertise and what they recommend. So is that a fair answer, Steve?
Absolutely.
Okay.
Another question for you. What tools would you suggest to assess risk with adolescents who are not known to have sexually abused but have been accessing child pornography? Any thoughts?
Yeah, I have some in development thoughts, because that's becoming a general issue for the population, the treatment population who work with adult sexual offenders, those who access, and we're talking about child pornography here, because it's not illegal to access pornography. And child pornography is such a broad area because it starts at below the 18th birthday. So you could be talking about somebody who's looking at 17-year-olds, and you could be talking about somebody who's looking at 5-year-olds. So I think we want to really kind of get our handle around, the things that we're really defining. Looking at child pornography in itself is considered to be a crime, sexual abuse. You're not allowed to distribute, of course, create or own. And I'm not sure the wording actually says look at, but it's on your computer, for instance, or it's in your pocket, or you own it. So it's a different kind of an abuse. And without going into the details of why is it an abuse, it's an arrestable crime. We don't yet know well enough how to assess these kind of things in adults, let alone in adolescents. And by assessing, I think one of the things we're wondering about is, look, it may be a real concern to us that this person's engaging in this kind of behavior, meaning accessing child pornography, particularly kiddie porn. But we don't know what the chances are if there's no other history of let's say, contact offenses, or even hands-off offenses, meaning exposure or voyeurism. If there's no history of that, we don't know well enough. Lots and lots and lots and lots and lots, magnified by, an exponent of 10. Lots of people use pornography. We know now that incredible amounts of people all over the world access child pornography. How many of them have engaged in other forms of sexually abusive behavior or will, and how much of a role does accessing pornography play in that? Really, I think I feel comfortable saying that it's definitely not my field of expertise. I'm not sure there's very many people who have that as a field of expertise because it's just developing. But certainly there's no real evidence that overall it leads to sexually offensive behavior, although it may for some individuals, and that comes back to the idea of comprehensive individualized assessment, because assessment instruments in their current state aren't necessarily going to catch that. The eraser, for instance, of the JSOP, you could catch excessive use of pornography in someone who's previously offended under the rubric of sexually preoccupied behavior. Sorry, I couldn't quite get the words out. So that's not a very good answer. It's a state in development. It comes up a lot, and I would imagine in the next 5 to 8 years we're going to see more coming out in terms of assessment instruments, or at least instruments that can help us assess risk. Again, you're really not talking about a forensic risk assessment in the sense that there's no prior history of sexually abusive behavior. Although they were arrested before, for instance, or got into trouble before for the use of child pornography, which is a sexual offense, then you have a static history. but doesn't mean it's going to lead to hands-on offenses. It may just mean they're going to continue to use child pornography. I'm aware of time, so let me.
You're doing all right, Phil. I'll let you know when the last question comes up. There was another question here about how sensitive the instruments are to non-sexual offenses. As we know, the sexual reoffense rates may be very low, but the criminal reoffense rates are, some reports up to 50%. So, how sensitive are these tools that you're talking about in terms of assessing, future criminal behavior of a non-sexual nature?
They're about the same as the empirical validation in general, meaning that literature is really mixed in it. The JSOAP has received the most research, then the eraser, but the eraser research is not anywhere near as much as the JSOAP research. So, and then everything else sort of drops behind that by far. So looking at the eraser, which is a really good example, the eraser, because of the way it's set up, in some ways, it's easier to measure because it's broken into four distinct scales. And so this is a perfect example. Some research has found that JSOAP has no empirical validity whatsoever, but others more typically find that one of the scales has more predictive validity than another in predicting either a sexual reoffense or a non-sexual offense, let's say burglary or breaking into a car or assault. The problem is you go to other literature and it shows just the opposite. It shows no effect. So having cautioned you that the empirical evidence is not strong, in fact, maybe it's not weak because there is some evidence, but it's really not strong. It's inconsistent. It's clear that the designers of the instruments understand that sexually abusive behavior happens in a context of other troubled behavior. It's not all necessarily going to be criminal behaviors, but for some of those kids, it is. And so the rates of non-sexual reoffense, Steve said, are higher, much higher. And depending on the study you read, they're anywhere from really, I've been part of several studies in which we saw really like a 700% increase, a 3% sexual recidivism rate, but a 21% non-sexual. So the rates of non-sexual could be anywhere from 5 to 10 times higher. So it's an area that we want to focus on, and it's an area that those instruments, I think, are sensitive to and can help you pick that material out. On the other hand, there are instruments designed specifically for that, but they don't look at sexual material. So.
Thanks, Phil. I don't know if you can answer this briefly, since I don't know what it relates to. You may. Do you know the -13? Does that mean anything?
Yeah. The -13. Jim Whirling, who is, again, as I said, the primary author of the eraser. There were two authors, but Jim really is the primary author. In the last year, put out. He is now the guest editor, along with somebody else, of the next issue or an upcoming issue of the Journal of ATS's Journal on Sexual Abuse. And that whole issue is turned over to protective factors, looking at empirical evidence. And Jim developed, it's really not an empirical instrument, but Jim developed a thing. I couldn't quite tell you what the dash stands for, desistance against sexually harmful behaviors or something like that. And the 13 is, he's listed 13, in effect, protective factors. And it doesn't offer you a way to mesh it with the eraser, which again is his instrument. But he's now added something to be used in a more complex assessment. And again, it's available. I have it. Jim's happy to circulate it. You can look him up. I think it's a long way from being where it's going to ultimately be the field of protective factors. But the dash is one of several instruments now. And by the way, the Mega also purports to measure protective factors. I'm not sure they're doing it quite the right way. I think they tend to recognize it as the absence of risk equals a protective factor, but that's got a protective factor scale built into it. So -13, assessment of protective factors.
Great, thank you, Phil. I'll be back to you in a few moments.
I'm going to switch off my camera rather. Yeah.
You can or you can't, however you see fit. It's fine.
I wanted to see your face.
Fine if you stay with me. As Phil mentioned, NEARI Press offers Joan, Tabachnick, David Prescott, and I team up to do a monthly research to practice newsletter, we try to take a look at cutting edge or controversial research papers and talk about the findings and the implications that might have for the individual clinician and for the field. So you're automatically, if you were on this webinar, we've signed you up. You can always opt out at any time that you want, and we certainly have a great discussion pulling this together at our end, and hope you'll enjoy what we give to you. It's short, it's brief, and we try to keep you updated on what the latest adolescent research is telling us. And if you like this webinar, you can see all our previous webinars, which are posted on our website at www.nearipress.org. I want to just tell you a little bit about our upcoming webinar on March 31st, Creating Sexually Safer Congregations, presented by the Reverend Deborah Hafner. Now, all of you know that this has been a very active part of certainly the Catholic Church, but not only there. So whether you're a member of a synagogue, a mosque, any church, or any religious organization that has community meetings, the idea of how you might safely integrate or deal with those in your community who might be abusive is a really important thing to look at. And the webinar will address why faith communities must renew their commitment to sexually safer policies and procedures, provide an overview of how denominations currently address these issues, and introduce the key criteria of a sexually safer congregation. And finally, discuss how sex abuse experts and treatment providers can actively partner with faith communities, which I hope any number of you are already actively doing. Now, finally, I want to thank our sponsors, who we wouldn't be able to hold this event without their support. The Center for Clinical and Forensic Services, the ITM groups, James Reynolds, PhD, the Massachusetts Department of Mental Health, Maple Tree Group Homes, the New Hope Treatment Centers, Rancho Earlo Society, Stevens Treatment Programs, Wayne County Juvenile Probation Department in Honesdale, Pennsylvania, the YERA Counseling, and Houston Transitions to Wellness and Counseling. Thanks to each and every one of you. We couldn't do this without you. We'd love to have 2 or 3 more slides so we wouldn't be able to read individually. We hope that you out there will continue not only to join us for webinars, but to think about becoming a sponsor. And for the last 2 webinars that we hold this year, we're offering a reduced sponsorship of $35 for an individual, $85 for an organization. We'll also give you a choice of one of our books for free. And please contact us at info@nearipress.org or call us at NEARI, and the number has been shown a couple of times. Just a reminder, the PowerPoint slides are posted on the website, and the recording will be posted next week. So for those of you who want to re-listen to Phil, and it was a rich and interesting webinar, you can do that. You'll receive an announcement when it's posted and a link to the certificate of attendance. Once again, CE credits are available. Go to the webinar page and find the link for the post-assessment test and the link to purchase CEs. And please complete the evaluation, and a link will be sent to you when you sign off. And to end this webinar, I just want to say to Phil, I'm sorry you took yourself off the screen. Just a huge thank you, not only for the webinar, but for all of your work that's helped guided so many of us over the years in assessment and other areas. You're just a rich source of knowledge and skill. And, you know, without just the plug in terms of the business end of this for NEARI Press, anybody who has the opportunity to spend 3 days of your training or join us for our 1 day at MESOC is going to get a rich and comprehensive overview of what I think is the toughest part of this work, which is to do risk assessment. So thank you, Phil. As we end this webinar, once again, we truly welcome your feedback. So please be sure to complete your evaluation form when you choose out the close out the webinar. We look forward to seeing you, hopefully when there's a little less snow here in New England. And thank you for being with us. Take care, Phil. Bye, everybody.